This is Ravina Rajwani pursuing third year BPT from RGUHS Bangalore. So, I am here today to speak something about cerebral palsy, and the points we'll include or cover today are definition, criteria for diagnosis, causes, classification, pathology, signs and symptoms, medical and surgical management, orthosis, therapeutic approaches to the management of cerebral palsy. First, definition. It is defined as a group of disorders resulting from permanent, non-progressive cerebral dysfunction developing before maturation of CNS affecting the locomotor system. The cerebral palsy is non-contagious motor condition that cause physical disability. Although brain lesions that result in cerebral palsy are not progressive, clinical picture of cerebral palsy may change with time. Primary impairment in gross and motor function. Associated problems caused may be cognition, seizures, vision, swallowing, speech, bowel and bladder, and orthopedic deformities. The criteria of diagnosis for cerebral palsy. Cerebral palsy can be diagnosed using Levine criteria or posture. Posture is a mnemonic. It stands for P. Posturing, O. Oropharyngeal problems like tongue thrust or swallowing abnormalities, S for strabismus, T. Tone, evolutional maldevelopment, E, and R is for reflexes. Causes of cerebral palsy. Prenatal, perinatal and postnatal etiology may be present. Prenatal causes: maternal infections, inflammation of placenta, Rh incompatibility, diabetes during pregnancy, genetic causes, and exposure to some radiations. Perinatal causes may be asphyxia, meconium aspiration, birth trauma, prematurity, disproportion, breech or rapid delivery, low birth weight, coagulopathy. Postnatal may be meningitis, encephalitis, lead exposure, drowning, shaken baby syndrome, brain damage, secondary to cerebral hemorrhage, trauma, infection, anoxia, motor vehicle accidents. Now, the classification of cerebral palsy. On the basis of severity level, basis of topographical distribution, motor function, or on the basis of gross motor function classification system. On the basis of severity level, it may be mild, moderate or severe. The child can move without assistance. The ADLs are not limited. In mild, moderate, the child needs braces, medications or any adaptive technology, and in severe, the child requires a wheelchair and will have significant challenges in accomplishing daily activities. On the basis of topographical distribution, that is the area of body involved or affected, are monoplegic, diplegic, paraplegic, triplegic, hemiplegia, tetraplegia and double hemiplegia. Paralysis means weakening and plegia or plegic means paralyzed. Okay, now on the basis of motor function, cerebral palsy is classified into spastic and non-spastic. Spastic may be ataxic or dyskinetic, and dyskinetic is further divided into athetoid and dystonia. Spastic cerebral palsy, it is the 70 or 80% of the total cerebral palsy cases. Cerebral cortex is affected, accompanies any of the other types of cerebral palsy and can be monoplegic, diplegic, triplegic, hemiplegic or quadriplegic. Athetoid or dyskinetic cerebral palsy have mixed muscle tone, often shows involuntary motions. Damage occurs to extrapyramidal motor system and pyramidal tracts. It occurs 10 to 20% of all the cases. The newborn or infants may have high bilirubin level in blood, and if it is left untreated, brain damage in certain areas may be caused, and that may lead to athetoid CP. Ataxic cerebral palsy is a damage to cerebellum, least common type of cerebral palsy, and patient may have hypotonia and tremors. Hypotonic cerebral palsy, location of damage is widespread in CNS, have musculature that have musculature that is a limp and can move only a little or not at all, called as floppy child. Mixed CP. Signs and symptoms of spastic cerebral palsy is seen along with any other type. Now the classification based on gross motor function classification system have 5 levels. Level 1 is walks without limitation, level 2 with limitation, level 3 with adaptive equipment assistance, level 4 self-mobility with the use of power mobility assistance, level 5 severe head and trunk control limitations. These are the pictures of all the 5 levels. Pathology. Periventricular leukomalacia is the most common finding in cerebral palsy. Corticospinal tract fibers to lower limb are medial to those of upper limb and paraventricular white matter. Thus, children with PVL typically have spastic diplegia. Bilirubin encephalopathy in basal ganglia is seen in athetoid cerebral palsy following a diagnosis of kernicterus. Focal cortical infarcts involving both grey and white matter are found in patients with hemiparesis and are typically related to MCA strokes. Brain malformations can be found on neuroimaging in approximately 10% of children. Signs and symptoms. Spastic cerebral palsy may have hypotonia, exaggerated reflexes, clonus, poor voluntary control, scissoring gait, low intelligence and loss of memory, and epilepsy. And synergistic pattern. Contracture deformities and wasting caused are adduction and internal rotation of shoulder, wrist flexion and thumb inside hand, flexion and adduction of hip, knee flexion, ankle plantarflexion. Extrapyramidal cerebral palsy may affect limb, face, tongue and speech, characterized by continuous muscular, worm-like movement. Postural instability, decreased movement in prone position, fluctuation of tone, reflexes are usually normal and muscles are able to connect. Decreased stability, difficulty to look up, emotional liability and arms are more affected. Sucking and feeding problems, delayed head and trunk control. Ataxic or hypotonic cerebral palsy may have incoordination, hypotonia, nystagmus, diminished reflexes, speech, visual, hearing and perceptual problems and joint hypermobility, dysmetria, incontinence, gait disturbances, imbalances and lack of trunk control and unsteadiness. Now, the medical and surgical management of cerebral palsy. Drugs used. Oral medications such as baclofen, diazepam and trihexyphenidyl as well as therapeutic botulinum toxin, that is Botox, are used. Surgical. Dorsal rhizotomy reduces spasticity. Joint and tendon release most often performed in hips, knee and ankle. Insertion of a baclofen pump usually during young adolescents. And also the orthopedic surgeries like bony correction of femur, termed as femoral anteversion or antitorsion, and tibial torsion. Secondary complications caused by spastic muscle generating abnormal forces on bones. Orthosis. Choice of orthosis is based on assessment of range of motion, foot alignment, voluntary control of movement in lower limbs and functional level of child. Orthosis supports the joint, assists the range of motion and corrects the deformity. The orthoses used are supramalleolar orthosis, ankle foot orthosis, knee brace, ankle foot knee brace, abduction splint and swash orthosis. Therapeutic approaches to the management of cerebral palsy include Bobath or neurodevelopmental therapy, conductive education, sensory integration, Adderley suit, aim-oriented management, advanced neuromotor rehabilitation, biofeedback, Dosa How, which is a Japanese psycho-rehab technique, electrical stimulation, early intervention, functional physical therapy, movement opportunities via education, patterning, pelvic positioning, physical activity training, strength training, targeted training, Vojta, training program which include 15 modalities by Phelps. Recreational program includes hippotherapy, saddle ring or hydrotherapy, alternative therapies like hyperbaric oxygen therapy, acupuncture and osteocraniosacral therapy. Thank you so much. See you all soon.